We're on.
Yep.
Yes, thank you. Thank you.
Hey, Tom. Can you hear me?
Yeah, who was that?
This is Bill Franklin. I was going to ask Tom a question.
Oh, go ahead, please.
Tom, can you hear me?
Yes.
Yeah, what was your blood work like that you wanted to go on the Proformin?
Metformin?
The Metformin, I'm sorry. I was thinking of something.
My blood work was all very normal. No, absolutely no high blood sugar or anything. You know.
Okay.
So I gave the paperwork of websites that Rick had given to me, and I handed it to him, and I said, I know I'm not diabetic or anywhere near it, and you and I both know that there's a history of people using this, and I know it's experimental, but I'd like to go on this. And he looked at it, and he thought about it, and he said, we could try it. We'll see what happens. You know, I was wondering about what if you took the 500 milligram pill and cut it in half.
Right. You didn't see anything. Some of those pills they don't want you to cut them in half because they have a coating that helps with time release and.
Yeah, I know. I don't want to just do that on my own. I want
to. There are two versions of the of Metformin. There's an extended release, which has the coating that was just mentioned, and there's my wife takes one that's not coated that you can cut in half. I don't know why you want to do that, but you can do it, but not with the extended release period.
The reason I'm talking about it is I'm a little bit afraid of taking it. You know, I have read about the positive things that can happen, excuse me, but I'm also a little afraid of creating a situation where I'm going to get things too low because I don't have diabetes and get my blood sugar too low.
Well, just make sure you take it with food. Don't take it on an empty stomach.
Right, yeah, I do take it with food, yes.
Is that the key, Jake? What's the story on that?
Well, I don't know if it's the key, but I do know when I had my surgery, they told me to stop taking. Told me I couldn't eat, of course, and they said don't take your Metformin because it'll lower your blood sugar too much. Mm. So, and my instructions on the bottle say take with a meal.
Okay.
Yep.
That's good advice. Thanks.
How do you know whether you have the pill you can cut in half or not?
Well, if you have the kind that you cannot cut in half, which is it'll say Metformin ER for extended release.
Oh,
that's
okay.
What I have. My wife got because my wife started this a couple of weeks ago, and I'm looking at her pills, and I'm saying this is not the same pill I take. It was the same strength, but a different pill. Hers was round. Mine looks like a pillow kind of thing.
Like a what?
Like a pillow, you know, kind of it's elongated a little bit and rounded at the ends.
Oval?
Not oval quite, but it's not, it's like a rounded rectangle.
I'm gonna run and get my pills now.
We're gonna have a pill comparison.
I got a question. Does anybody know of anybody who had a problem after taking it?
I honestly haven't heard of somebody way back when. I think told me they had a little diarrhea, but honestly I can't remember who, and then it went away. But I honestly can't remember who that was.
Hey Rick, this is Jim. Rick, this is Jim Harrington. I take it. I was taking 3 tablets a day, 1,500, and I've been taking it almost a year now. And I cut it down a little bit sometimes, but I don't really feel anything. But every time I have my blood work done, they always measure the sugar, and it's always okay. But it is something to be concerned about. But I mean, people who have diabetes can take 4 pills a day, right? 2,000, 2 grams. It's a lot, but I mean, they do it, and been used for years. But I've never had any problem with it. I guess, you know, why not just take more of it and just monitor your blood sugar? It's the thought. I mean, you're going to why cut a pill in half? Just take the whole thing, you know, and work on up if you can do it.
My pill is round, and it says 70 on one side and Z on the other side.
Mine is round too, but you know, I mean, Metformin is so old. I mean, probably a lot of people making it so doggone cheap. I'm not sure whether it's a pillow or a square, but you know.
It says Metformin HCl, 500 milligrams.
That sounds like the one my wife has.
So that's the extended release?
No, that's not the extended release.
So that's the one I could cut if I chose to.
Yeah.
Oh, okay.
You could probably cut the extended release one in half too, but they actually tell you that you might find the empty capsule in your feces.
Yeah, I read some things about that.
And because it doesn't digest.
Yeah.
Boy,
That's for the.
you guys are doing some great research. This is how I learn stuff. And people say, how do you know that stuff? I just listen to my guys, that's all.
What does everybody think the biggest advantage has been since they've taken it?
Well, I can tell you one advantage is weight loss. It's an appetite suppressant, and the weight you put on with Lupron, which since I'm on Lupron for life, comes off with the weight loss. Not everybody experiences this, but it's one of Snuffy Meyer's big things. You know, it's an appetite suppressant. According to Snuffy, it's the only appetite suppressant. But the second day I took it, my appetite went boom right on down, and it's continued that way. And I've lost about 20 pounds.
Oh, I'm all for that.
Yeah.
Well, I mean, each person can view it differently. My colleague is diabetic, and he takes 4 pills a day, and he hasn't lost much weight, so I'm not sure.
I've lost about 20 pounds also.
Wow.
I mean, it can really work. It's but you got to watch your blood sugar, or as I do, I eat cookies. You know.
Wow.
Right,
How do you watch your blood sugar? Just with your normal blood
Yes,
test?
when I do the PSA, they give me a whole blood panel. I mean, I'm not
Okay,
saying
so
everything, but I can
okay.
always watch my blood sugar, and I'm watching my red count and everything. I'm on Zytiga, but just comes naturally, and it's quite normal.
How often do you get your blood checked?
Good question. Every maybe month and a half or so, I go to LabCorp, and yeah, something like that. Then I go get my shots, Lupron, Exgeva, and so forth. So about every month and a half, watching my PSA.
Okay, guys. Well, listen. I mean, this is a great conversation, which we launched right into, and I don't even know who's on the call yet. So this is great, and maybe we'll come back to it. And but you know, I do think that there's a real positive from a prostate cancer standpoint from taking the Metfrmin. So so I'm really pleased to see that some of you are having success. And like I say, I said earlier on, my buddy Nigel got Chuck Ryan to prescribe it to him. Tom just got his guy at Fox Chase to prescribe it to him. Jim Cameron is having a little difficulty, but I'm sure that somehow or other we'll figure it out. We'll help him and we'll get it done. So
Rick, you know, my colleague can't get Sloan Kettering, and that's Dr. Scher to prescribe it.
Yeah,
so he's one of the top docs in the world. So I don't know.
I know he's going to have to go through his GP. I guess so. So, but you know, have him.
I can't say it's actually helped me. I'm sorry.
Say that again. What was that, Jake?
I was just going to say I can't say it helped me. It helped with my PSA, but because my PSA is still going up. But it's all I know is it hasn't hurt, and it does keep my blood sugar a little bit lower than it would be normal.
You see, the problem is that, of course, without these good clinical trials, which I suppose we really don't have, and this is what the docs are saying, we don't know whether to what extent it helps. But there's the argument that if you didn't take it, your PSA might be going up even faster. So, as long as it doesn't hurt, I always say it's kind of like chicken soup. So, anyway, let's see.
Can't prove a negative. Can't prove a negative, but
well, that's right.
As long as it doesn't hurt, it can't hurt.
Yeah. So, let's see who's. Let me see who's on the call. Let me tell you who I know, and then there are some people that I don't know yet. So, I know that we've got Jeff Ledoux, and Jeff, we're getting noise, so maybe you could mute. We're getting quite a bit of background noise because I know you've been on there since I opened the call. So that would be great if you could help us with that. Jeff Ledoux, Tom Van Zandt, Bill Franklin, Jim Cameron, Peter Kafka, Jim Harrington. So give me a shout out if I haven't called your name.
Frank Kelly.
Ron and Susan.
Frank Kelly. Hold on, Frank Kelly, and then Ron and Susan. Well,
Correct.
okay, great. And anyone else?
Sylvester Mann.
Hi, Sylvester. How are you? Welcome back.
Thank you. I'm doing fine.
Good.
Len Sierra's here.
Hello, Len Sierra.
Hello, Rick.
Have I missed
Rick,
any?
did you mention me? It's Eric. I didn't
Oh
know
yes,
if
I didn't because I didn't write you down. I waved to you, but I didn't write you down. Sorry. I saw you, of course. All right, so let's go down the list again. So Jeff Ledoux, Tom Van Zandt, Bill Franklin, Jim Cameron, Peter Kafka, Jim Harrington, Frank Kelly, Ron and Susan, Sylvester Mann, Len Sierra, Eric Bookbinder. Did I get everybody?
I count.
Who was that?
Jake.
Sorry, who was that?
You don't even mention my name.
Oh, Jake? Did I not put you down? Oh, jeez. Sorry.
Feeling left out here.
Yeah, I'm sleeping on the switch. All right, so let's...
Mike Tamales.
Hello, Mike Tamales. Welcome.
Hello.
Mike
I
Tamales.
see several phone callers.
Yeah, well, some of them I didn't get, but I'll get. Like I didn't know. Let me just get the numbers. So Ron and Susan, just say something to me. Anything.
Hi.
Hi. Okay. So that was, I think you're number one. Okay. And let's see who else. Frank Kelly.
Yep.
Give me a shout. Oh, okay, I got you. You're number 4, so I'll change that. And let's see. I don't know. I think. And then I don't know who number 6 is, but we'll find out. Okay. Well, I'll put in a few as as we go here. So we don't have any new people today. Now, one thing I just wanted to mention, which Jake reminded me, because he mentioned his wife, is that tomorrow, as most of you know by now, we have the first call for our caregivers. And if you think that your own caregiver would like to attend, then just please make sure they know it's going to be at 7 o'clock Eastern, and you can work it back from there, the call tomorrow. You'll dial in or come on the platform exactly the same way you're doing it today. So tell your significant other, your caregiver, whoever it is, you can show them how to do it. And I will be on the call initially. I'm looking to find somebody to replace me because I don't want to inhibit the call. And I'm concerned that if I'm on that call, that the caregivers might feel that they can't be as open as they would otherwise be, because I have the relationship with all of you who are on this call right now, and including the caregivers that attend regularly, like Susan and Lisa. But you know, there may be things they want to say, and they're not comfortable with my being there. But at the same time, initially, Renata needs some support. She's not comfortable, and it's a lot to do on your own, and of course we don't know what the response is going to be like, but we're really excited about kicking this call off. And just one other thing on that score is that we're looking to expand to do other calls as well, and that are not prostate cancer related. So if any of you have any friends that are active in a particular condition or chronic condition, and you think they would be interested in moderating a call for whatever it is, please let me know. I'm particularly interested in starting calls for diseases that affect mobility, like Parkinson's and MS, where it's just very hard for people sometimes to be able to get physically to a support group. So I've got feelers out. I also want to do one for some of the other cancers. We'd like to do one for breast, for lung, for colon, maybe for melanoma. So we're going to keep pushing this, but the constraint is finding the moderator, we've got to get the right person, and so that's just a little appeal that I'm going to put out. So anyway, let me move down the list and see who would like to speak today. Jeff Ledoux, anything for you?
I think I'm going to be quiet today. I don't really have anything new to add.
Okay, well, you'll figure it out as we go along, but thanks, Jeff. Tom Van Zandt, how about you?
No, I'm not having any big problems right now.
Okay. Anything? Did you not say you're seeing your VA guy tomorrow? Anything you want to review about that?
No, not really. It's just a checkup I have to go to.
Okay. Bill Franklin, how about for you?
Yeah, I was just going to mention something about my exercise program. So
excellent. Yeah, let's talk about that, because all you guys want to take Metfrmin so that to lose weight, but I don't want you to stop exercising. Jim Cameron, how about you?
I think we answered all my questions before we started.
Okay. All right. Peter, how are you? How about for you? What have you?
Good. Yeah, I'd still like to talk about insufficiency fractures for my buddy up in Napa.
Excellent. Yep. Jim Harrington, how about you?
No, nothing tonight, Rick. Thank you.
Okay. Frank, how about for you?
Yeah, you guys might want to know a little bit about the bipolar protocol.
Okay, absolutely.
And I have seen an acupuncturist, and if somebody wants to know a little bit about that.
Oh, great. Yeah. No, we'll come to you. Ron and Susan, how about for you?
Anybody know anything about Xofigo and the side effects and what it's all about?
Yeah, we can talk about that.
Okay.
Sure. Sylvester, anything for you tonight?
Not tonight, thank you.
Okay. Len, how about you?
Well, if we need to fill in some time, I could talk about new imaging techniques that I sent to you a couple of weeks ago.
Yeah. Eric, how about you? Can't hear you. You're muted.
I think it's my mic.
I can hear you now. No.
Yes. I have a couple of things I'd like to talk about.
Sure, absolutely. Jake, how about for you?
Not really. My PSA went up 1 point, but it's still well below 10, so probably not worth discussing.
Okay. Well, we may have time, so I'll put a little question mark if we have. And Mike, okay. Mike Tamales, how about yourself?
Nothing's changed in a week, so I'm just here to listen.
Okay. Let's. And has anybody else come on the line? Did I miss anybody there? Guess not. All right. Bill.
Can I ask you a question?
Yes.
I had to step away for a minute or two, and when you were talking about the caregivers,
yes,
and you said you needed somebody. I thought Renata was going to do that. So I got an email from her the other day.
Renata is doing it, but we need a co-moderator. You know, these calls are much easier if there's two of us. I always get a lump in my throat when I say this, but I miss Dom. When Dom was on the call, we had, he would take the names, and so if there was a piece of research to be done, one of us could do it whilst the other one was moderating, and so it's better and easier if there are two people moderating than just one person.
Right.
And so
I think we all miss Dom. I know I do.
So, do we all miss Dom? Yeah, we do. So anyway, I'm just going to I'll do a lot of the technical stuff for her so she can concentrate on the moderating. I'll gather the names and do all of that. And then eventually what we're trying to do is just to try, we'll find somebody. She may have someone, and sooner or later we'll slip in another person. Okay. And then I may just audit from time to time just to make sure the calls are going well. And but I don't expect to be doing that call regularly. But that was what we were saying, Jake. So anyway, yeah.
Rick,
yes.
So are calls not going to be recorded?
No, we talked about that yesterday, and we exchanged emails on the caregivers call about recording the caregivers call. Initially, we're not going to do it, and then I think what we'll do after about 3 or 4 sessions is we'll throw it out and see how the people that are regulars on the call feel about it, whether they feel comfortable with us recording the calls. We don't record the inner conversation calls either. These calls are less technical, they're more emotional, and there's a concern that people are not, they're not as comfortable recording those calls, and we don't want to inhibit the calls, and so we've just decided initially we're not going to record them, but we will revisit that once we get underway and see how people feel about it. But we're really open, both Renata and I are really open to feedback on that. If people feel strongly that they want those calls recorded, we would like to hear from you. Anyway,
how loose?
Yeah.
Yeah, go ahead. I was going to say, how loose is your definition of a caregiver?
It's pretty loose. I mean, we if there's somebody out there who is supporting you in any way, shape, or form on a regular basis, then they're a caregiver. I mean, they don't have to be the person that accompanies you to all of your appointments, but if they, one of the big purposes for this call is that there really is a lack of support for caregivers, and whilst the patients, the people who have the disease themselves may not see it, that there can be a lot of stress that's created through this disease for people that are around them. And we want to support those people that are around you, and we want them to be able to speak freely where they need that support. I mean, I've heard it from other caregivers who have called me up to ask me questions and who really need some support, and they're frustrated, they're upset, whatever it is. Now, some of it's positive, some of it's negative, and I do expect that there will be some, what I like to call technical stuff going on, where we'll exchange information about, how to do things or get things done on an easier basis than they're being done right now, and but there's also going to be people coming on the call who are saying, you know, I don't know what to do. I try to do my best, but it just doesn't seem to work, or whatever it is. I don't know what they're going to say. But I just, I mean, the purpose of the call is to provide support. And the other thing is that we're opening this to all. I mean, it's going to have a strong bias initially to prostate cancer, obviously, because that's where we know the caregivers are. Having said that, we're opening it up to all stage 3 and stage 4 caregivers. So we're going to have people on that call who are taking care of people that have that have cancers other than prostate. And so again, I just want to give a heads up because we think that the issues are probably very similar. So so if you know, I would suggest if you've got someone in mind, have them join. And if they're not comfortable or they don't like the call, they don't have to come back. But we're not going to exclude anybody. Can I answer anything else before we go to Bill?
Rick,
yeah.
Jake again. Can I revisit that foreman for just a second?
Yes, go ahead.
Okay. Somebody mentioned the stomach upset with Metfrmin. I believe one of the reasons for the extended release version is to minimize that. It's similar to aspirin, the enteric-coated versus regular aspirin.
Mm-hmm.
The extended release has a coating on it, and it's supposed to be released slower throughout the day rather than a sudden jolt to your system. And that might very well help anybody who has some stomach that's upset about it with it. So just a thought.
Okay. Okay.
I'll shut up.
No, please, thank you. I mean, no, we appreciate that. All right, Bill Franklin, you wanted to talk a little bit about exercise, and I think, let me see, I think there's at least, how many people? I think there's 3 people on this who may have signed up for the MAN plan. 3 or 4 people that may have signed up for the MAN plan who are on this call right now. So
you just reminded me about that. I wanted to look into that more. But
yeah,
when you had Bill on here a few weeks ago, it kind of inspired me, you know, with what he was talking about, because when I was younger, I was a really active swimmer, and I did a lot of running and biking too. I'd only ever done one triathlon in my life, and it was like a mini one. But for him to have said he did what he did while he was on Lupron and, you know, another treatment, that was just awesome.
Unbelievable.
I've felt so much lack of energy and just exhausted sometimes that I couldn't. It's a vicious cycle, you know. You don't have any energy, so you don't exercise, and you don't exercise, it gets worse. So, really,
yeah.
The only thing I wanted to say was, so he kind of inspired me, and I was thinking about what can I do. So I decided that I would do a 5K. So I started a 5K training plan, and I was mentioning it to a guy I work with, and he said, well, that's great. I need to get in shape too, so I'll do it too. I'll train at the same time, and then we'll run the race together. So what I ended up doing was sending an email out to my entire office. About 60 people work there, and I got 12 people respond saying that they wanted to do it. So some of them are only going to walk because they can't run for other reasons, you know. But so my point is that if you think you'll get the response, or even if you're not sure, you know, if you reach out to other people, you'll get support. And that's an important thing, because if I went out there just on my own and was training, it's easy to skip a day, or it's easy to say, I don't feel good today, I'm not going to do it, and then you might fail at your attempt to finish your 5K training. But if you have a group of people that are supporting you who are also doing it, and then there's a little bit more commitment there, and you support each other. And my family was all for it too. My daughter is training with me. She's 10 years old. So that's a great thing.
So I just want to make a couple of quick comments on that. And John Shane, who is pretty sick. In fact, I have to follow up and see how he is. He just did that bicycle ride in Massachusetts that supports Dana-Farber that they do every year, and he did it with his daughter, 180 odd miles over the weekend. You raise a really interesting point, Bill. I mean, some of you guys know that many years ago when I got diagnosed, I was really anxious to see how we could make it easier for people to exercise when they got a diagnosis, particularly men who were on hormone therapy. And we started a program, and that program, I have a website called Medafit, MEDAFIT. I'll put it in a second, so you can go there. And it became a program at UCSF which offers exercise counseling to anybody that has cancer. And I've been trying to extend that program, and if anybody thinks they may have an interest in extending it in their local community, then please let me know, because we'll work together. But one of the big elements of that program, which never was adopted by UCSF, but I still think is hugely important, is a buddy system. And I'm a huge believer that if you can find a buddy to exercise with, it not only makes your exercise way more enjoyable, but it makes it easier to exercise. I mean, most of you know that I row, and when you sit there sometimes on that rowing machine day after day, it can drive you nuts. I mean, it's no fun, but you got to do it. But I always find that if I've got somebody sitting next to me and we're rowing on the machine together, it goes much quicker. A lot of times I watch something. I can put something on the computer at the rowing club. I can watch like yesterday, I watched the second half of a soccer game from the morning, and I got through 40 minutes without any bother at all, whereas a lot of times now I'll struggle if I'm rowing on my own to get through 20 minutes. And if you've got somebody doing it beside you, it's even better. The other thing with having a buddy is you have an obligation to them. So if you've agreed that you're going to do something every day and they call you up and you don't feel like doing it, you don't back out of it because you owe it to them. So I encourage all of you strongly on this call, find yourself an exercise buddy. And one of the things that I've suggested to the guys that are on the MAN plan is, maybe hook up with someone else who's doing the MAN plan from amongst our group, and see if there's a way that you can't, do stuff together or at a similar time so that you can support each other. And pretty soon I'm going to reach out to the woman that's who's coordinating the MAN plan at AbbVie, and I'm going to suggest to her that they try and get a buddy plan. I mean, I love what you just did, Bill. It is fantastic. I'm going to put it on the blog on ANCAN. So send me some, just email me some information on what the 5K is and when it's coming up. And I just think I think it's fantastic. Just one other example, and I'll throw it open, is that our friend Richard Foodie, who's often on these calls, but he's now back in rehearsals for another one of his shows. But he's found tremendous support with his exercise, first with Donna Wilson at Memorial Sloan Kettering, which Len knows about, and he looks forward to those classes. And now he's part of their Dragon Boat racing team. And it makes the exercise so much more fun and much easier. So I'm throwing it open. Let's talk about exercise and any thoughts anybody has.
Is Donna Wilson going to be doing the program on the 31st, the 5th Monday?
No, no. But let me come back to that. I'll make a note. I'll talk about the 5th Monday of this month at the end. But let's stick on the exercise right now. I don't want to get off it, Peter, if that's okay. Any other, tell some of you guys who are on the man plan, any feedback yet? Jeff Ledoux, did you get your package? Jeff? I guess not. I think maybe he's busy exercising with his bands right now. Anybody else?
No, Rick.
Yes.
Rick, I'll speak up for a minute. What I did is, I'm not on the man plan, but I did join a local gym, and just the fact that I have to pay every month motivates me to go.
That's good. That's good. Tom Van Zandt, didn't you ask me for a man plan connection?
I did ask for it, and there was some problem with the telephone number. I got the wrong person, and then I never got back to it.
Okay, well, do you have the right telephone number now, or can I give it to you?
May as well give it to me.
Okay, so I'm gonna just give me a second here, and I will find the Gloria. Okay, so here's the telephone number for any of you. It's 844-295-7526. I'm going to put it in the box. 844-295-7526.
Okay, thanks.
And all you got to do is call them up and tell them that you're with Answer Cancer, and they will give you a number, and that number you have to fill in on the website, and then they'll send you out a package. Who else? Ron Silvera, you asked me for a man plan number, if I remember correctly.
Yes, I did. I haven't received my package as yet.
Okay. And is Jeff...
I'm waiting.
You're waiting. Is Jeff Ledoux back with us? What happened to Jeff Ledoux? Oh, I don't know. Let's see. He shows he must have gone for a pizza or something. I don't know. Well, he'll be back. So yeah, I just encourage you to do it. I know they said it would take a couple of weeks, and it's probably, so I think those of you who did ask for packages, they should be coming through pretty soon. The only person I know who got it was Jeff. Any other thoughts on exercise?
Well, Rick, this is Len. I just reinforce what you said about the buddy system. That's incredibly important. When I use Planet Fitness, and when I go there and some of my friends are there and we exercise together, we'll talk, and time goes by so fast.
Mm-hmm.
Makes it much easier.
Mm-hmm. Thanks, Len. Yeah, and I mean, I actually think it could be quite fun if a couple of you guys, 3 or 4 you guys, go onto this man plan thing together. I mean, what I may well do, in a couple of weeks when you all have your packages, is maybe I'll circulate a little email if it's okay with all of you, and so that you know who's on it, and then I'll leave it up to you guys to reach out amongst yourselves. But if you don't want to do the man plan, I mean, the beauty of the man plan is that you don't have to go anywhere. You can do it in your house. You can use the exercise in your house. But if you don't want to do that, do what Bill Franklin just did, which is amazing. It's amazing. I mean, Bill, I just can't tell you how, kudos to you. It's fantastic. And 11 people in your office. That is really, really outstanding. I mean, just fabulous. Fabulous. When's the race, Bill?
Well, there's several different
5Ks in that time frame. So when I started training, I told them I was starting the program, and so they all kind of hopped on. It's called Couch to 5K. It's from coolrunning.com, and it ends on the Thanksgiving week.
Okay.
It's the last day of training, so everybody was like, well, you know, I go to my mom's house for Thanksgiving, or et cetera, et cetera. So,
okay.
And there's several races in that time frame, last week of November, beginning of December, but we've been kicking around the idea of just doing our own, you know, and set up a course and just do it and then have our own picnic and everything too. So.
Wow. Make it a fundraiser for Answer Cancer. How about that? That'd be
I'll
good.
see what I can do.
That would be good. I think we're close to having a logo, so I've got to go back and do some work on that. We're close to having a logo, and so, you know, we're getting a little bit more real. So there you are. All right. Well, if I can't find Jeff Ledoux, look, he may have just left. So if I can't find Jeff Ledoux to tell us what was in that package that they sent him, then we will move on. Okay, Peter, you're up.
Okay, the purpose of this one is not to scare anybody, but just to see if anybody has some feedback. Just a quick synopsis. When I was in San Francisco getting radiation, I made good friends with a buddy in the changing room there, in the men's changing room. He's a Gleason 7, had a prostatectomy 5 years ago, and he had a reoccurrence and was there for radiation. They didn't put him on Lupron, so he's never been on ADT. And he's a little bit older than me. He's in his early 70s. He's from Napa Valley, and he's in good shape. He's an active guy. Anyway, he called me the other day, about a month ago. He'd been hiking with a buddy up in Lake Tahoe area, not really strenuous. He had a 35-pound pack on his back or something like that. They went out for several days. And it turns out when he came back, he had trouble walking. And it was very painful. He had some x-rays taken, and they identified it as what's called an insufficiency fracture. Insufficiency fracture in his coccyx area, the bottom of the pelvis there, where the spine meets the pelvis. And he was baffled because he didn't fall, he didn't hit anything, he didn't sit wrong. And he started looking it up and researching it. And one of the indications of insufficiency fractures is from radiation to the pelvis. And he said, whoa. And then he just had come through this 6 months before, and they can't prove that that's the case, but he called me up to warn me about that possibility, and I'd never heard of this before. And so he's on crutches. He's been on crutches for over a month now, and he's going to be on for another 3 months. He can't walk on his own. He can swim and so forth, and being in water helps him out. But being on land, getting up and down and so forth, it's extremely painful. And there's nothing else they can do for it except keep him on crutches and let it heal. So I just want to throw it out and see if anybody else has ever heard of anybody having that kind of reaction to radiation or weakening of the bones and the pelvis from that kind of treatment.
Anyone?
I've never heard anything about radiation treatment doing that. I of course, I was counseled on the ADT, to take extra vitamin D and calcium because it can weaken your bones. But I just went through radiation this summer, and my oncologist never mentioned anything like that.
Mm-hmm. Has anybody else heard of this from their oncologist or anybody that they've known?
Well, but after radiation, I felt really weak in my hips. It's only now I'm starting to feel a little bit stronger, but I felt like really weak after radiation, and still till today.
Peter, did your friend have any bone density tests prior to this?
He's doing that. He's doing that now. I don't think he did. He was never on ADT. He just had a prostatectomy, and then they didn't put him on ADT when he was going through radiation at UCSF, even though he had like 40 or 42 blasts of it. So it's a mystery to him, and he's talked to Dr. Albert Chang, who is his radiation oncologist, who said, Albert's comment was, yes, this is possible, but it usually shows up about a year after. It's rare that it would show up, within 6 months. So that was an odd statement. So, it's not a denial. He didn't deny that it's a possibility, but there's no proof that that's what it's from.
A lot of those.
What it is hairline fractures in the lower spine.
And is it due to osteoporosis or osteopenia or something like that?
I guess you could make a case for that, but I'm not sure he has that. I don't think so. He's a pretty active guy, and I think he's generally in pretty good health.
Yeah, I mean, the one thing that I find a little puzzling, which would be the question to ask the radiation oncologist, is to what extent the lower spine is impacted by radiation that's given to the pelvic area. And, I would suspect that with some of the, certainly with proton beam, which I think the beam is a little bit shorter and it doesn't penetrate so far, I doubt that there's an impact. But even with the IMRT, I mean, if it's focused on the pelvis, I wonder how far away that it is. Now, maybe when at the rectum, I don't know. I just don't know. But I'm wondering how much radiation the coccyx actually gets.
I don't know. I don't want to belabor this one. It's worth looking up, called insufficiency fracture, insufficiency. And it's more common with women, of course, because they're subject much more commonly to osteoporosis and osteopenia. But it can happen in guys, and one of the causes listed is radiation therapy. Okay, I just wanted to throw it out there because I had never heard of it either.
Well, just
guys,
yes.
I'm reading an abstract here. Insufficiency fracture after radiation therapy, where they say recently many studies reported the development of insufficiency fracture after radiation therapy in gynecologic cancer, prostate cancer, anal and rectal cancer. So I guess it's fairly well known.
Len, could you post the abstract, the URL for the abstract on the chat?
Yes.
Thanks.
Yeah, sure.
I mean, the only thing I would just mention to you is that, and this happened to me, was that I discovered that I was osteoporotic when I started my hormone therapy because I had a bone density test done, and I was pretty amazed because I never would have thought that I had an issue. So I would hope that since I think most everybody on this call is at least on Lupron, or maybe there's one or two that are not, but most everybody is on Lupron, that you're getting bone density tests fairly regularly. I'm not saying, probably not more than once a year, but you should be getting a bone density test on an annual basis just to make sure that you don't have any issues there. Now, a lot of the guys that are and who have METs are also getting some sort of bisphosphonate, either Zometa or Exgiva, and that should be stabilizing you. I mean, in my own case, I got Zometa once a year because of the risk. It wasn't because they saw bone mets, but it was because of the risk. And I changed the exercise that I was doing to do more weight resistance exercise, and I improved my my T-score, which is the bone density score, from -2.4 to -1 over 3 years. So, that was a combination of the two things. So you can reverse it. But please, if you haven't had a bone density test in a while, then I encourage you to ask your docs to give you one. Okay, let's move on to Frank Kelly.
Rick?
Yes.
Is your suggestion for the bone density, is that only if you're not on the Zometa or Exgiva? I've never had one, but I've been on Zometa for 4 years.
You're on Zometa, I at least raise it with your docs. If you're not on Zometa, you're not on Exgiva, definitely you should get a bone density test. If you are, then raise it with your docs. But what they may say is, well, even if you're low, we don't know what else we could do for you. But at least raise it with your docs. And you know what? There is something else you could do. I mean, if you have low bone density and you are on Exgiva and Zometa, you can be doing more weight resistance work because it works. It really does work. So, my feeling is you should push for it, because if you find you've got an issue, then you can start incorporating a more aggressive exercise routine. So that's why, that would be my suggestion. Ask for it. If they don't want to give it to you, tell them, you want to know, because you could also be doing some more weight resistance work. Just watch out, and they'll say to you, in case they say to you, well, you should be doing that anyway. But then you say, well, we're on the man plan, So, okay, Frank.
Yeah, I started the conversation 2 weeks ago about this bipolar treatment, and started it on last Wednesday.
Mm-hmm.
And it's a month shot, once a month, of testosterone in your butt, which is a massive amount of testosterone. I don't know what it is. And then and that's 28-day cycle. And for the first 14 days, you take 100 milligrams of etoposide once a day.
Mm-hmm.
And out for 14 days, and then you drop off the etoposide, and the testosterone shot takes over. And after 28 days, you repeat the cycle for 3 cycles. And at that point, depends on what your PSA has done, etc., they might put me back on Xtandi, see if it comes back in or works better than it's been working. And that's all I know, other than the first 5 days I felt miserable. Today I felt a little bit better. But it's basically a oral chemo is what it is. I didn't realize this is what they're doing to me. But I don't know if anybody else has checked into it or has thought about it, or as a doctor mentioned it, or it's coming out of the University of Washington from Dr. Schweitzer, who did a study, and this is no longer a phased trial. It's actually open because it's already approved drug for cancer. I don't know. I just figured I'd try it and see what happens. Hopefully the testosterone picks you up for a while, but hopefully you don't do a big roller coaster thing.
So Frank, can you just repeat the regimen again? You get a large testosterone shot initially.
That lasts a month.
Okay.
And then for the first, or 28 days.
Right.
And the first 14, you're taking etoposide, which is a chemo by mouth drug. 14 days, so you're taking 28 pills of that. And then they leave you to the testosterone, which is supposed to quiet down the receptor cells because they have more access to testosterone. Then they hit it up again after the 28-day cycle. Pretty simple to do it right out of my doctor's office. Actually, they're going to send the packages here so my wife can go ahead and inject me once a month with the testosterone. But I have only been on it 4 or 5 days, so I don't know quite what it'll do to me, other than I have felt kind of awful. It's hard on the stomach. I don't know. That's about what I can say about it.
How many cycles do you go through of this?
3 cycles, three 28-day cycles.
Okay. And what is the... Go ahead.
Nobody's ever mentioned etoposide before, so this is something new.
What is the purpose of the etoposide?
Is to, I guess, you're yin and yang in this thing. You're given the testosterone so the receptors relax, and the etoposide comes in and hooks into them with less receptors, because I'm told that the longer you're on Lupron and Xtandi, more of the cancer will make more receptors to grab whatever testosterone it can. And by giving it a big boost of it, they cut back on their receptors. In fact, I think my wife read that sometimes it over boosts them to the point where it kills some of the cancer cells just because of the extra testosterone. I don't know.
Richard?
The study kind of read somewhere along the line. They only did this with 16 or 18 people. And one guy died, so that took one out. One guy had a perpetual hard-on, so they had to take him out. And so it gives a potential for maybe a little sexual activity at some point. I'm not to the end of the month to know or not. But of the 16 or 14 that were left, something like about 50% of them showed no lesions. And it's not, I'm not qualified to talk too well about the test, so I don't know what condition all these people were in or what levels they were taking them.
Right.
Something like 30% showed remission and no activity in the tumors, and 20% were no show of any improvement. So pretty good percentage chances of showing some kind of improvement on your cancer and your lesions.
So those who showed, did it show a reduction in lesions for some of those guys, that they'd had lesions before and then they went through this therapy and the lesions were reduced?
That's my understanding. Yeah.
Okay. Jake, I'll come to you, but I just wanted to make one comment, which is that I know that etoposide is a chemotherapy, and I've known of a couple of guys that have tried it, and I just was reading that with if you have a P10 mutation, P10 is a gene, and if you have a P10 mutation, that it is it may have some impact for that mutation, but it isn't supposed to be that significant. But it may possibly, and P10 mutations are pretty current. I know, Frank, that your Foundation Act work or your Foundation 1 work didn't show too much. Was that, by the way, your foundation work, was that a liquid biopsy or was that a tissue biopsy or both?
Well, we tried to do a tissue biopsy, and they showed the needle going into the cancer,
That's
but
right.
nothing came out. So there was nothing there, and then I went to the liquid blood test, and they showed no actionable genes there.
Now, I mean, the only thing is, and I know it's actually an opportunity to raise the issue. I know it's controversial because Len and I have been going back and forth, but you still have a prostate, correct?
Yep.
And that prostate wasn't radiated, correct?
Yep.
So Len, I'm going to give both sides in a second, but there is an opportunity to analyze a prostate biopsy, and the prostate, the tissue biopsies are much more likely to show something than the liquid biopsies, and this is something that you might want to review now, particularly given that your doc is somewhat tied into University of Washington. The work that came out of the University of Washington said that metastasized lesions are very homogeneous, meaning that it doesn't matter where in the body they were to sample, there's better than a 90% chance that those lesions are all going to be similar genomically. So the genomic sample, if they took it from your hip, if they took it from your rib, even if they took it from from soft tissue, they're all going to show the same. Now, the question is, what about if they took it from your prostate? Because we also know, with some other work that's been done recently, that the prostate is not very homogeneous, that it's heterogeneous. It's pretty much meaning it's different in different spots in the prostate. However, that is what we know from men that have early disease. And the work that was done there by Way, where was that done, Len? Remind me, where was the Way work done?
No, I'm sorry, I don't remember.
Okay. Well, that work, I believe the testing was on men that were fairly early in the disease. So what we've been trying to figure out, and this has involved Len and myself and Professor Bill Burhans and a couple of and some outside people, Tony Crispino and one of the guys that was on the study at Washington. What we've been trying to figure out, and we can't get a definitive answer, is as the disease progresses, does the genetic makeup in the prostate conform? And so it's just the same as all the other lesions all around. It's not clear. It's clear from this one study, based on that one study, and it's tough to base something on just one study, but it's clear on that one study that all of the samples were very similar. The work actually refers to them checking the primary tumor, which is in the prostate, and all of the metastasized tumors, which are all around the place. And it does say that they're homogeneous, but I'm just trying to find out to what extent that they intended that meant the prostate too. It's really not clear. I've asked somebody to take a look at that for us, Tom Harding over at Clovis Technology, who's a real expert. But Frank, for somebody like you, it could be very pertinent, because it's way easier to get a prostate sample than it is to get a bone sample.
Yeah, my oncologist didn't want to go back and do that. He figured he'd try the blood test. And as far as he could tell, everything was normal. but you're right, you're only analyzing 60 or 80 of them instead of 200 of them.
Absolutely.
But I said something about that, and he just said, no, let's do the blood test. And when it came back, no genes actionable, he just decided that was good enough.
Well, I mean, you know, he decided that it was good enough on the liquid biopsy, but you've got to push him now and see if you can get a tissue sample done. Because maybe there's something in the tissue sample.
Well, that's what I was trying to do. Is I said, why don't we go back in and take another hip sample? And he just said, no, let's try the blood sample. But yeah, I agree with you. Maybe I should push. Well, I'm losing my oncologist at the end of the month. So
Oh, really?
The guy out of the same office. Yeah, he's retiring.
Okay. Well,
So
you know,
go with the new guy.
Talk to him. Talk to them about doing a prostate sample, and tell them that it's based on the work that's being done. Lisa, make a note of this if you would, and I'll try and send you. I'll make a note to send you the paper afterwards. It's based on the work of the Kumar paper, Kumar, out of University of Washington, and Pete Nelson, who wrote a little article, which I'll also send you a link to, if I haven't done so already. And Nelson is the sort of the supervisor, he's the last name on the paper, which usually means he's like chair of the department or something. But it's based on the Kumar, and on that basis, you know, you want to ask for a prostate sample, and you want to have that analyzed. And Len, I mean, have I been fair to both sides?
Yes, I think so. And by the way, that Way paper on heterogeneity,
yeah,
believe it or not, that comes from Roswell Park.
Oh, that's right. Of course, that's
where
right.
Our buddy Bill comes from.
That's right. Yeah, I remember now. Yeah, it comes from Roswell Park. But I think that heterogeneity paper is early in the disease. It's not late disease. Which, you know, which is,
yeah, I think it.
And guys, the reason that's important too is because it doesn't affect you so much, but you know, people that just get diagnosed are doing all these genomic tests, Oncotype DX, and I forget the different names of them off the top of my head, and they're doing all these tests, and they're basing decisions on one sample from the prostate, and you know, you could take the sample from the prostate somewhere else and they may get a completely different result. But these are guys that are in a much earlier stage of the disease. That's why that Way paper was so, it caused a stir. I don't want to say it was controversial, but it caused a stir. Anybody want to ask Frank anything about the bipolar therapy?
I do, Rick.
Go ahead, Jim.
I don't understand about the toposin part of it, but as far as ADT, do you stop that before you, like so many months before you do the testosterone, and then restart the ADT so many months afterwards, or?
No, you're doing the ADT all the way through.
You continue doing the ADT all the way through, just like you do normally.
Yeah. My oncologist at first, he said I didn't want to understand it, I didn't believe it's true, but after going through the University of Washington study, he found out, it convinced him that the overage of testosterone actually affects the cancer in a way that it weakens it. So you stay on the Lupron, and then you come back in after three rounds with the Xtandi again. Or if it's so helpful, you may stay on this. I don't know. I don't know that much about it yet. This came up last week, and boom, off we were running, and there we are.
But you're going to continue with ADT just like you have been all along.
Yep. I'm told I'll never get off ADT, so.
Right, you're all right.
Yeah.
Okay, well, thank you.
Well, the other thing I wanted to talk about is I know we've talked about acupuncture before.
Oh yeah, right.
So I finally stepped up to the plate and got some appointments. There are 8 series of acupunctures, two a week. And I did notice that it made some of my bone pain go away. It also made the hot flashes quite a bit lighter. And he's working on trying to relieve my stomach. And
wow.
Well, I've only done 3 out of 8. If he's successful, I'll keep doing them after that. But I did find, first off, the whole thing is quite relaxing. They will give you a lot of health and nutrient advice because that's part of what they do. And these guys are also chiropractors, but I don't need that. But I just found the experience quite good. My insurance is covering it so far, which I was really surprised about. But I may only have so many sessions that are covered, and then they drop the protocol from my insurance. But it's only $80 for about an hour. We were thinking about going down. Well, actually, we are going down to the ranch in Tucson, Arizona here in a month.
All right.
And they wanted $200 for an acupuncture session. So my little town here has quite a few, and this guy's got all the letters behind him.
Let me work on that. Let me see if I can find you an acupuncturist that could. I mean, are you going to Canyon Ranch? Is that where you're going?
Yeah, when we go to Canyon Ranch.
Yeah. So yeah.
I'm only going to be there 10 days, so I'm not skipping too much of what I'm doing.
Well,
but I'm going to take an acupressure session down there just to see what that does.
Well, forget the prices in Canyon Ranch are not representative of the prices in Tucson. If you need an acupuncturist down there, let me see if I can come up with a name for you. You'll just let me know. There's some really good people down there because Andrew Weil is out of University of Arizona, and so he's attracted a lot of people. There's a very good University of Arizona Cancer Center on Campbell, which is actually named after the guy I used to work for in Tucson, Donald Diamond. But I could probably come up with a name for you if you want if you need a treatment down there. You don't have to be paying those ridiculous Canyon Ranch prices.
All I'm going to be doing down there really is massages and meditations and things like that.
Right.
So I think I can get away with 10 days without the acupuncture.
Okay.
And then come back up here and finish off the sessions.
Okay.
But I did find it. I just wanted to get the word out that I did find it helpful with some of the symptoms.
Well, there's some good. There is some good research on acupuncture relieving hot flashes. And I've said for a long time on this call, I've recommended guys try it. I mean, the big issue is it's not permanent. You have to keep topping it up. So as Frank said, you go and you have to, it lasts maybe 3-4 weeks and then you have to go back. But it does seem to work, and I'm delighted to hear it works. And I'm not surprised that it's helping you with your bone pain, because I've suggested to guys also that they should try acupuncture for bone pain. So
see, I'm not that sure about it yet because I only had my first acupuncture 2 days before I was on the chemo.
Right.
Chemo. So basically, all the stuff came back in real quick in a flash. But I do notice that some of it's sticking with me, especially the hot flashes.
Okay.
As far as I'm going away or being a lot mellower. And I see him once this week because he's out of town for a while, and then I'm back to a 2-week schedule again, or a twice-a-week schedule.
Okay. Anybody want to talk about the acupuncture or know about the needles and where they're sticking them or anything else?
Hey Frank, this is Jim Gammon. You said your insurance paid for it. Are you on Medicare?
No, I'm not old enough. I'm 61. So my regular insurance was paying for it, but I was surprised that they would, because it's kind of like going to see a chiropractor or anything like that. They think it's voodoo science. But I guess acupuncture is now being accepted into the main flow of alternative medicine. I do think it's worth checking out, though, if you guys have hot flashes and bone pain and things like that, because I want to avoid painkillers as much as I can because of my intestinal problems. I just don't want to get into that. My bone pain ain't real bad. It's just starting to ache in the back and the knee and places like that. So I'm not sure how they figure out where to stick the pins, because my hurt back, all the pins were on the front side of me, and yet it still seemed to relieve some of my back pain. Didn't want to question them because there's so many acupuncture points that you can pick and choose from, and I don't know what they do. I had a couple needles fall out, and I stuck them back in about where I thought it was, and he said, well, that's close enough. So.
Nice one, Frank. We like that one. Good man.
Well, I didn't know what the deal was, because I felt one fall out on my arm, and I thought, well, I remember seeing 3 there, and this is the middle one, so I'll just put it somewhere in the middle of the other 3 and 2, and he said it was good enough. So
close enough for government work, right, Frank?
Yeah. But one thing I found him is they're very concerned. At least this guy is very you call it kind of ergonomic, or what do you want to call it? He's very sensitive to your needs, and he knows I'm terminal, so he's working real hard on just trying to relieve the problems with me with the acupuncture.
Frank,
I'm impressed by him.
Frank, we're talking about terminal. How long is it that you and I have been talking now? Is it 3 years? How long is it?
About 3 years.
3 years. And you told me you weren't going to be talking to me in a year. So 3 years from now, we're going to be talking again, and I'm going to be reminding you. Just saying.
Okay.
Okay.
Well, I'm at the end of most of my normal procedure protocol treatments, so
we don't know what's coming up.
I know that's
we don't know what's coming up. Wait till they wait. The next thing is we're going to do a tissue sample on your prostate and see what that tells us. There's always something.
Yep.
Right. Okay. Anyone else for questions for Frank?
This is Jim Harrington. Well, Frank, you go to Canyon Ranch. I assume you go to Tucson or you go to Lenox?
Tucson.
Yeah, well, I'm also a member of Canyon Ranch, and I'm telling you, if you spend 10 days, you're going to, I don't care what happens to you, you're going to have such a good time and enjoy yourself, relax, and go through all those programs. But it certainly is a pricey joint. That's quite correct, Rick. I never had acupuncture there, but it's a wonderful facility. I've been to Tucson and Lenox and in Florida. So anyway, enjoy yourself in 10 days because it's a hell of a nice place to go and relax.
My wife really wanted to go because she needs to have the peace and relaxation from all the stress.
Oh, it's a terrific organization. It's just very expensive. There's no way to slice it. Being a member, it's about half price, and be a member, and it's about half that price. But you get a lot, and so have fun. Best wishes to you.
We're going to try to. Yeah, I appreciate it.
10 days, you'll have a good time.
And if you want to, Lisa, if you want to sort of escape and have a good meal one day, my buddy Janos has one of the finest restaurants in the Southwest there. It's called Downtown Kitchen, and he's a James Beard Award winner, and used to have a couple of other restaurants. Downtown Kitchen's been open now about 2-3 years. If you go down there, you tell Janos that you're a good friend of mine. And it's really outstanding food. And by the way, if you happen to come across a tenant, I'm losing my tenant on November 1st, so I need a tenant for a small 2-bedroom house. If you could keep your eyes open too, that would be very helpful for me personally.
Well, Well, most of the people I know from California are moving up here, not moving back down.
Well, the rent's cheap in Tucson. I'm going to be lucky if I get $1,000 for that house. I'll tell you. So the rent is certainly cheap enough in Tucson.
We're not moving to Tucson.
Oh, okay.
All
right.
All right. A few people that I do know that go down there for winter snowbirds that get out.
Yeah, no, but you'll love it. I mean, Sabino Canyon, I used to run 2 or 3 times a week in Sabino Canyon. It's really pretty up there. I think anyway.
I've been out in the desert working on a ranch before, right down the Mexican border, and it's pretty dry and desolate down there.
Yeah. All right, so we're gonna move on to
Paul Hobson wants to say something.
Oh, hi, Paul Hobson. Welcome. Please say something.
I've just sent you through a paper a few years ago. They came across a study where they worked out that in one case, distant metastases were reseeding the prostate bed. So they were able to work out that it wasn't just the prostate sending out metastases. New ones were coming back to the prostate bed from elsewhere.
Mm-hmm.
So I just raised that in terms of your homogeneity.
Yeah.
Whether there mightn't be stuff coming from elsewhere after a while back in the prostate.
Paul, could you also post that? Do you have a link to that paper by any chance?
Yes, I do. I'll post that if you like.
Would you post it so Len can see it too?
Yes, okay, will do.
Thanks a million. It's just my gut feeling. I'm not a doc, I'm not even a scientist, but it's just my gut feeling from what I'm reading that there's going to be a fair amount of homogeneity in that prostate, and I just know it ain't easy a lot of times to get a decent bone met to sample, and it is easy to stick a needle in the prostate, and sometimes it's a lot less uncomfortable than having to do a bone biopsy. And it seems to me that if we could do a prostate biopsy and rely on the prostate biopsy, we'd be doing a lot of men a big favor. So we'll just watch this space. I mean, we're going to keep pursuing on that one. I was going to ask Eric before you, Len, because Eric had a couple of issues, but he's stepped away. As we can see. No, he's back. Hello. Oh, okay. What's for dinner, by the way? I see somebody working very hard in the kitchen. Anything good?
She's cooking for herself. I'm not going to get any of it.
Oh, wow. That's not fair.
Yeah.
Oh. Okay.
We're leaving at 6 o'clock tomorrow morning to spend a week in New York. We'll be staying out right off Times Square.
Oh, good. Okay.
So
that'll be fun.
Yeah, I went to see B.J. Miller.
Oh, good.
Yeah, to ask him, if he had any ideas about my problem with being out of breath and lack of stamina. And he told me to take the Norcos more. I don't know if that's a good idea, and he also prescribed some Ritalin for me to see if that would help. So I've just started on those. I guess I'm a little better, but on the other hand, I'm not trying to do anything major. I don't want to wear myself out before I leave.
Right.
So it's just it's an ongoing issue, and no one's really been able to come up with why I have that problem. And it is a side effect of Xgeva and Zometa. I've cut the Zometa down to once every 3 months on the recommendation of I think Dr. Agarwal. My Berkeley med-onc was kind of like questioning it. I told her to talk to Dr. Agarwal if she had any questions, but that I wanted to cut it down. So now I'm doing the Lupron in coordination with the Zometa. I get both of them once every 3 months.
Well, the half-life, Eric, on that Zometa is awfully long. It's like about 2 years or something. So,
right.
You know, you can certainly be taking it for quite a long while. Getting off of it for quite a long while, and it stays in your system for a good period of time. So for those of you who don't know, BJ Miller is a palliative care doctor at UCSF, and he gets rave reviews from everybody who sees him. So he's
an incredible.
Go ahead.
I was say he's an incredible guy. I mean, he's really empathetic. He's, you know, and very knowledgeable, and I think he knows whereof he speaks, being a triple amputee. So, you know, I've just never had a better feeling with any doctor I've ever been to.
Yeah.
And he gives you, I mean, he should teach bedside manner to most of these other doctors.
By the way, just on that score, Renata Flowers, who's going to be moderating that call, knows BJ real well, and she's had a lot of exchange with the Zen Hospice, where he's, I think, the medical director. He's
the executive director.
He's the executive director, and she's actually going to be speaking at their annual fundraiser. She's going to be their guest of honor at the annual fundraiser. So she and BJ know each other very, very well. So so it speaks also well for Renata as well. If any of you are interested, I actually haven't seen it, but I need to do it. But he did a TED Talk, so you could go to TED Talks and put in BJ Miller. I'll put his name down here for you guys so that you can, in case anybody wants to look him up. But he's supposed to be absolutely phenomenal. So go ahead, Eric. I know what I was going to ask you. Did he? So the shortness of breath thing. I mean, what did he say about that? Nothing, huh?
He did not have a clue. I've had, my lungs and my heart both checked, and they're both fine. And, it's nothing there. Mm-hmm. So, but, as I said, it is a side effect of, the Med-Onc started me on Zometa because I was having the problems. And, it is a side effect of Xgeva, but then it turns out it's a side effect of Zometa too. So I don't know if it's that. No one really knows what it is. It can be quite severe. If I pick up something heavy and carry it for 30 or 40 feet, then I'm out of breath. And if I work at a task, even one that doesn't require much lifting or energy, I get out of breath. And I mean, it's severe to the point where the last time I had something I had to do, and I got it done, and then I immediately came in and lay down and went to sleep for 2 hours. So I don't know.
Eric?
Yes.
Eric, have you noticed the difference when you get your Lupron, when you get your 3-month Lupron shot, the first month of the 3-month shot? Do you feel any different?
No, I haven't noticed that any particular. Okay. I'm at the end of the 2nd month since I had one, and I'll pay more attention to it. I'm not, it's not something. I do know that after a meal, it's much worse. So when I eat, then it makes it much worse. So just a list of symptoms, but no solutions.
Yeah, I have a similar situation, and I was doing great for a long time, and then I got another 3-month shot a month ago. And when I returned here, I have the same issue. I was moving a picnic table for some friends over the weekend. I was moving some furniture for a friend. And any time where I've got to use my muscles for an extended period of time, as opposed to the gym where it's like 12 repetitions and I do something else. But if I'm stressing myself, moving the table or moving the couch, I just get exhausted. And I've got to sit down and catch my breath and regroup. And I never used to have that, but all of a sudden in the last month or so, it's hit me that way. And I thought it was maybe just the effect of the 3-month shot all of a sudden hitting me. But I've been on Lupron. This is my second time on for almost a year now. So I don't know what it is either.
Well, if I find out, I'll let you know. But so far,
okay.
no one has any ideas. I know that all the things that they've looked at, are normal for me. My blood work is all normal. Let's see what I have. My potassium was a little high. They asked me if I'd been eating too many bananas. But that's, my PSA is still going up. So I don't know. But, as most of you know, my PSA has never been very high. But so going up for me it's up to 9 now. So.
Now you said that it's a side effect of Xgeva, but you're off Xgeva and you're taking Zometa now, correct?
Right. Look up the most serious side effect of Zometa. Same thing.
Same thing, huh? Okay.
Yep.
Okay.
Yeah, so I didn't know why, that was supposed to be a solution, something else to the same problems. But
okay. Peter, this is not good news. You may have to go easy on those bananas, man. Check your potassium. Peter, for those of you who don't know, Peter has bananas growing in his garden, so which he assures me tastes very different to what you get in the store. Is that true, Peter?
Very true. When I was at UCSF, I was meeting with Greta about nutrition, and she suggested having bananas, eating a banana a day. And I looked at her and said, Greta, I've never bought a banana in 25 years. When I want a banana, I just go out and I pick a bunch. If they're not ready, I wait a few days.
Are they better than store-bought, Peter?
Oh, there's no difference. I mean, you can't compare them. They're sweeter. They're exceptional. Yeah, they're called apple bananas in my yard. I've got hundreds of trees. I've just got to beat the rats to
them. Eric, go ahead.
I think that's all I got.
That's all you got? Okay, well, we hope you have a terrific trip. Are you going to see your cousin Peter?
Probably not. His mother just died, and he's actually out here. So.
Oh, okay.
I won't see him in New York, and he lives way upstate anyway.
Right. I haven't heard from him in a couple of years now. So, but I'm glad I did hear from him. Otherwise, we wouldn't have found you. So.
I wanted to ask Eric a question.
Yes.
If I may.
Please, Jake.
On the Zometa, I've been on it for every month for the last 4 years, and you said your doctor changed you to 3 months. Was there a reasoning for that? It was based on somebody's recommendation?
Well, the side effects of Zometa, can be very dramatic, with the necrosis of the jaw, and right. I'm having some trouble with my teeth, so they're trying to cut it down to see if they can deal with the problem with the teeth. So.
Okay, that's the only reason for it.
Well, it's what at UCSF it's what they recommend now. They don't want you to have it every month, so that's just their recommendation.
Okay, I know Rick has said that to me before, but my doctor says no, there's no problem. You need to get it. So.
Well, I mean, again, I'm not a doc. I'm not giving medical advice, but I know a lot of guys that get taken off after a while, and they go back on. They're on it for a couple of years, 2 years, 2.5 years. And then they go back on because the life is so long. So it just might be worth revisiting that with her. Every month for 4 years is quite a long time.
Yeah, okay.
Paul
right,
Hobson,
you,
haven't there been some studies which suggested that the dose that's currently prescribed is higher than necessary, and so people have been dropping the dosage back following those studies?
I've read them, but I can't think of them, but I think you're absolutely right, Paul. Absolutely right. You know, another reason to talk to her about that. Let's move on because I want to check in with Jerry Dean's just joined us. Hey, Jerry. And
hey, I'm in.
And I want to check in with Jerry. I want to check in with Susan and Ron about Xofigo. And if we've got time left, just want to get a quick update from Len on the, so we have about 25 minutes, so we may get through all of this. Ron and Susan, you asked about Xgeva, about Xofigo, or also called Radium 223, I believe. You want to just, you want to elucidate a little?
Sure. When we went over to see Dr. Antonakis over at Johns Hopkins, he spoke about the ARV7, the blood test they give you.
Yep.
And I don't know which way it goes, but 30% of the guys go, if you got this, you go to this line of treatment. There's like 70% of the guys don't have it, and they go to the next standard of treatment, which is the Xofigo. Now, right now, I'm on Xtandi, and it seems to be doing well.
Mm-hmm.
And he told, Dr. Antonakis told me, as soon as your PSA goes up one notch, call me, and we'll do the blood test.
Mm-hmm. Mm-hmm.
So I want to know what that, and Jerry didn't do well on the Xofigo, towards the end.
Right. That's Jerry.
Yeah.
We're talking about Jerry Carnelia.
Correct.
So let me just give you a little bit of background and tell you what the Xofigo does, and then I'll open it up to anybody that's done it who's on the call. I haven't looked and seen if there is anyone, but we can talk about it some more. So first of all, with the ARV7, the ARV7 tests for a mutation in the AR is androgen receptor variant 7, and if you're positive and you have that mutation, and about 30% of men do have the mutation, then you're probably not going to do very well with either Xtandi or Zytiga. If you do well with Xtandi and Zytiga, it's likely you don't have the mutation, or if you want to test beforehand, because these drugs are so expensive, you can check and see if you're negative or positive. And if you're positive, you have to decide whether you want to spend the money. There are people like Dr. Steve who says, look, doesn't matter whether I'm negative or positive, I'm going to do it anyway. But there are some people that say, okay, you know, it's not going to be the best treatment for me, so I'm just going to look at a different treatment. One of the treatments that you can look at, and you can do this at the same time as Xtandi or Zytiga, that's enzalutamide or abiraterone, is Xofigo, which is a radioactive treatment that goes that's injected, and it is attracted to the bone. So the idea is that they inject you once every, that there are 6 sessions, and I think they're monthly. Mike Tamales is, we have one person, Mike Tamales is doing it right now, and the radioactive material is attracted to the bone mets, and it's had some success. It's a treatment that's made by Bayer. Bayer's pushing it left, right, and center. This whole issue with the Griffeys is the Ken Griffey and Ken Griffey Jr. They're spokespeople to some extent for prostate cancer, but more to the point, they're spokespeople for Bayer and for Xofigo. And there's nothing wrong with that. This is not a criticism. I mean, I'm delighted that they've gotten us more publicity. But that's where the Griffey, you've seen the Griffeys being involved, and that's how they got involved, was through Bayer's action. Bear also has a pretty good website, yeah, Bear has a good website that you can see. They've got a lot of good information that they're putting out on Xofigo. Now, the downside of Xofigo is that because it's attracted to the bone, it can affect your bone marrow. And if your bone marrow is already compromised, and this was the situation with Jerry, God rest his soul, that when Jerry was on a trial, and the trial was to get chemotherapy and Xofigo at the same time, in the protocol had always been it's only been around 2 or 3 years, but the protocol was you could get Xofigo before you had chemo or after you got chemo, but you couldn't get it at the same time. So they did a test, they did a trial, and one of the sites was at UCSF, and you got the drug and the chemo at the same time. And the impact for Jer was that it really depressed his blood counts. His platelets went to hell, and his white count went to hell. His red count dropped significantly, and it wasn't that successful. It was really the beginning of a slippery slope for Jer that finished up with him passing away less than a year later. So one of the big issues is to make sure you don't have what's called myelosuppression, which is poor but bad bone marrow, where the bone marrow isn't producing the healthy blood that it should be. And so I always encourage people to be very sure that if they're going to consider Xofigo, that their blood counts are healthy.
Okay.
Now, Mike Tamales, do you want to just tell us about, other than Mike, is there anybody else on the call who has done Xofigo? Okay. Mike, you want to tell us about your first Xofigo shot? Are you still on? Did we lose Mike? No, Mike, are you with us, Mr. Tamales? Oh, he must have stepped away. I'm sorry. He shows us still being on, but he might have stepped away. It's basically just Steve Bornstein just did a shot around the same time as Mike last week. I don't think the side effects, at least as reported, are particularly bad. I mean, I'm talking about the immediate side effects. We've talked about the the myelosuppression, but I don't think that there's too much. Peter Kafka, did the doc talk about any immediate side effects on the Xofigo?
No, but he is watching the blood work.
Okay.
You know, Mike does blood work every month, and he's keeping a close eye on it.
Okay. So, Ron, that's what we know. I mean, keep tuning in, and you know, we'll get people that other people have been right the way through it, who are on this call, and you know, we'll get Mike Tamales when he's back with us. We'll get Steve Bornstein, and you know, if you want, I can let me know, and I'll put you in touch with them so that you can correspond with them. Certainly with
right.
You know, with Dr. Steve, definitely he'll be very forthcoming.
It's you know, it's off in the future.
Right.
Right now, like the beginning of, well, this week I have to go get a PSA, and I'll have a follow-up and see how the Xtandi is working. So if it's still dropping my PSA, I don't have to go to Hopkins and get that AR, whatever it is.
V7.
V7, yeah. And Susan and I are going away for about 2 or 3 weeks in the national parks in Utah.
Oh, you'll love it.
Oh, I hope so.
Oh, you'll love
But
it.
I don't know about November. What do you about? Should I bring skis?
Oh yeah, you might. It could be. You know, you could have snow. It's going to be cold in Zion and in Bryce, I'm sure. But it's going to be cold in Zion. But when was it? A year and a half ago, I think for the third time I hiked up to the top of Angel's Landing, which is I love Zion. Zion is like a cross between Sedona and Yosemite. It's just awesome.
Mm-hmm. Ah, good. Well, we're going to be doing that, and we'll maybe miss one or two of your calls.
We'll forgive you. We'll absolutely we'll absolutely. When are you leaving?
The end of October here, right the 29th.
Okay. All right. So you know, we've got a ways to go. I'm going to be off in England between the 16th and the 27th. So but yes, well, you'll have a fantastic time. I'm going to send you some pictures of me on the top with my. I'm actually going back to England for my goddaughter's wedding, and I've got pictures of myself and my goddaughter on the top of Angel's Landing from about 2 years ago when they came to visit, and you know, they said they were gonna. They were all coming. The whole family were coming to Vegas. I said, I'm not interested in Vegas, but if you want to go to Zion, I'm in. And they said yes. So I flew up to Vegas and we went to Zion. Okay, so Jerry Deans, talk to us. I know that you've got some. So for those of you who don't know Jerry, Jerry's a board member at us too. We've known each other now since the end of 2014, and we correspond from time to time. And I got a note from Jerry saying that things may be changing, and just give us the update, Jerry, and let's see how we can help you.
Can you hear me okay?
We can hear you very well.
Okay. So I've had the cancer. I've had both surgery and radiation, and the cancer started, we found the cancer in my lungs back in 2006, and got on Lupron at the time, and it knocked it out relatively quickly, and probably about 8 or 9 months. I was it was in remission and stayed in remission for, I don't know, 3 or 4 years. Came back to my lungs again in 2010. And Stuffy Myers is my doctor. He put me on ketoconazole and, let's see, Bival Dot, and put it in remission in about 4 or 5 months. Stayed that way for another 3 or 4 years. In 2014, it came back to my lungs a third time. This time, we did Leucine and Xtandi and Firmagon, and it's gotten more resistant to treatment. It dropped my PSA. I was a PSA of 0.37 at that time when we found it in my lungs in October of 2014, and the Xtandi brought it down. Let's see, 1, 2, 3, 4 months it went down, and then it started back up again. So it started to gradually rise until about March of this year, and then it started taking off more rapidly. So I saw Dr. Myers again 6 months ago, and so I suggested that we try ketoconazole because I had a good response to ketoconazole when I took it, and he was okay with having keto along with Xtandi. So I've continued Xtandi, continued Firmagon, and and added into ketoconazole. So it had reached, at that point, my PSA was like at 0.209. And so when I took the ketoconazole, it started back down, and it stabilized a bit. So right now, the last PSA I took was it was at 0.238, and the last 2 CT scans, the lesion in my lung was not evident. Wasn't you couldn't see it. It had disappeared. But the CT scan I took last week, it's back again at 9 millimeters. So it's and I don't know if the keto, if I took the continued to take the keto, if it would stabilize it or continue to bring it down. But at any rate, I'm seeing Dr. Myers this week, and we've talked about a number of things. We've talked about CyberKnife. We've talked about apparently I am PD-1 positive, and he's mentioned the possibility of Opdivo. We've talked about chemotherapy, starting that, and so those are the possibilities that we've considered. So I've had some good success along the way, and this is the 4th time it's metastasized to my lungs. It always comes to the same place, and it comes to a place in the lower left lobe, and it's a place where they can get to it and get a sample or biopsy from it.
Mm-hmm.
And of course, Dr. Myers has it sent off to Caris, and they tell me what it will respond to. Right. So that's where we are now, and I'm feeling good. I'm not having any symptoms. I'm exercising regularly, feeling strong. I guess this would be a good time to do chemo in terms of my physical ability.
Mm-hmm.
When I take a Firmagon shot, it kicks my butt for about a week or two, probably about a week or so, and then I recover from it. And the keto wore me out for a while, but I've acclimated to that as well. So if anybody's got any thoughts or ideas, I'm interested in listening to them.
So Jerry, hopefully you saw the note that I sent you back today or last night. I can't even remember. The one thing that really screams at me, which I would strongly suggest that you review with Snuffy, is that Zytiga abiraterone is kind of a supercharged ketoconazole. It works much the same way that ketoconazole works, but it's much more effective and much stronger. Now, Snuffy started you on enzalutamide rather than abiraterone, and you seem to respond to the enzalutamide. It might be worth thinking about dropping the ketoconazole and the enzalutamide and trying the abiraterone, which you would have to take with prednisone. Are you taking prednisone with the ketoconazole?
Taking a little bit of hydrocortisone.
Okay.
I forget what the dosage is, but just a small dose.
So the prednisone is to keep your adrenals active, because the ketoconazole and particularly the abiraterone can suppress the adrenals, and if that happens, there are all kinds of nasty side effects, which are reversible, but they can give you a lot of grief for several months, and you don't want to get into that cycle. So you take the prednisone, and then when you stop, you come off the prednisone, and you do both slowly. You go onto it somewhat slowly, and you come off of it somewhat slowly. But the one thing that, I'm not a doc, and it's just my observation, but I just wonder whether, since you do pretty well on ketoconazole, you might do very well on abiraterone, and it might be worth trying it out. The other thing I wanted to say to you, we can have the chemo discussion, and I think you listened to we had a really good chemo discussion, excuse me, about a week ago, and I think you listened to that call. I actually have a buddy who's on Opdivo, which is nivolumab. He has lung cancer. He started it about 3 weeks ago. I actually saw him earlier today, and he's doing pretty well on it. He's tolerating it nicely. He's tolerating it better than Herceptin, because he was HER positive, and so he was on Herceptin for quite some time. This is with lung cancer. And then it stopped working, and so they put him on to Opdivo, and he seems to be tolerating it pretty well. He does feel the fatigue from it, and there is fatigue associated with it. But I just wanted to give you that heads up, and again, if you wanted to talk to him about what it's like taking the nivolumab, I'd be happy to put you in touch with him. Caris is good, but I do think that from what the guys have been telling me, the guys that I talk to, they feel that Foundation 1 is really good and better. And there are some people who feel you should be sequenced on a panel that's from a center of excellence. So in your neck of the woods, that would probably mean going to either Hopkins or Duke, would be the two closest to you, both of whom have really good genitourinary medical oncologists. So, I'm not suggesting that you stop seeing Snuffy at all. I'm just saying, well, maybe there are some other ideas, and there are some other options in terms of sequencing. I would suggest, when did you last send a sample to Caris?
That was October of 2014.
So, there's a very good reason to send out another sample, because this disease changes. And what you saw in 2014, I would say before you started Opdivo, consider getting another sequence, because you want to make sure that you're still PD-1 positive, probably are, but you want to be sure, and you want to see if there's anything else there, because this disease changes. And a sample that's 2 years out of date, I've heard enough of the experts say they would rather have something that's more current. So, and you could get a blood sample done too. We talked about that earlier in the conversation tonight, but it's just not as good. If you can get a tissue sample, you're going to be better off. And, there's no reason why you couldn't send it to Caris and Foundation 1. I don't know about Caris, but Foundation 1 are pretty good about costs. They're basically back charging the pharmaceutical, so it's not costing anything.
When you say a liquid blood test, a blood biopsy, are you talking about circulating tumor cells, or?
No, it's a little different. It's pieces of the tumor actually break off and get into the bloodstream. Little bits of DNA from the tumor, and they're referred to as SNPs, SNIPS. And those SNPs can be analyzed, and certain people, Foundation 1 is one. I suspect the one that Snuffy's going to like is Gardant, Guardant, but I would probably go with Foundation. And they have the technology to access and extract these little DNA SNPs and then to analyze them. The problem is that the panel that they analyze them against is much smaller than the panel that they analyze the full tissue sample against. So for men who don't have an easily accessible tumor, they can rely on, the only thing that they can rely on is the liquid biopsy. And this is different from the circulating tumor cells.
Mm-hmm. Okay.
Anybody else?
Paul Hobson, could I just come in?
Yes, of course.
Following the PCRI conference, Eugene Kwon spoke at the PCRI conference about imaging and how they were starting to map the way that metastases developed and spread in the body, and they were finding now that many more Mets developed in the lungs, which they hadn't picked up to such an extent previously. After the conference, I asked Dr. Kwon how they treated, where there were lung Mets, how his team treated the lung Mets. His response was, if they were a solitary metastasis, as it appears this case is, they surgically removed it. If there were multiple Mets, they then tried chemo. But I just thought his comment, particularly that it's a single Met, was worth passing on.
Yeah, thanks, Paul. And since Snuffy was there, he may have had some exchanges with Eugene Kwon as well. Have they thought about excising it? Have you ever had it excised before?
I did a wedge resection the first time they biopsied it. So I guess they probably got pretty much all of it at that point in time. There are some other nodules that are not as easy to get to that seem to be positively correlated with this one place in the lower left lobe. But we've never determined whether they're actually prostate cancer or not. They've remained stable throughout the coming and going of this nodule in the lower left lobe.
Mm-hmm. Mm-hmm.
There was some discussion about removing it the last time, but we didn't take that. We didn't take that approach. We did a needle biopsy of it before he put me on Xtandi and Firmagon.
Well, I mean, he may, you may encourage Snuffy to have a chat with Gene Kwon and see.
Mm-hmm.
Obviously there's some knowledge there, and thanks for that contribution, Paul. The problem is to be sure that's the only spot, because there's oftentimes we can't see the other spots.
Yeah.
And it's the level of imaging, and sadly, Len, I'm so sorry, but we don't have time for the imaging discussion. But maybe
that's okay.
Maybe next time.
Next week.
Yeah, there's always next week. So Jerry, I mean, there's a few things. Chat with him about excision. Chat with him about abiraterone. Chat with him about a new biopsy. I mean, if they're going to excise it, they can biopsy it at the, there's enough material there that you'll be able to send it to different places. And to some extent, I just encourage you to stand up for yourself in what you want, because Snuffy can be persuasive, and if you think that you would like it biopsied in more than one place, you just tell him I want it biopsied in more than one place. If you, you know, I don't want to tell you to be assertive on the abiraterone, and I'd be really interested to hear what Snuffy thinks, but I do know that abiraterone is very similar in how it works to ketoconazole. When they were doing trials, people who had been on ketoconazole were excluded from entering the trial.
Well, I have a question then.
Yep.
Do you know of people who started out on Xtandi that stopped responding to Xtandi and then switched over to abiraterone and did well that way?
Yeah, I do. I do know of a couple of people that got several months out of abiraterone after they stopped on Xtandi. Again, I don't think those people responded as well to ketoconazole. And I'm going to post something for you right now in the that I recommend that you listen to. Actually, I don't have to post it. It's on the website. It's on the Answer Cancer website under webinars. There is a discussion by Chuck Ryan, who Snuffy will know well, who was the principal investigator for abiraterone, Zytiga. And it's about a 20-minute discussion on Xtandi versus abiraterone and the sequencing. And he'll talk about abiraterone and Xtandi. You'll get good information out of that. I haven't listened to this in several months, but it's a very good. In fact, Dr. Steve Bornstein, who's not on the call today, listened to it and told me what a good webcast it was. If you can't find it, just send it to me. But it's right there on the webinar page towards the bottom. Hold on a minute, and I'll pull up ANCAN, and I'll tell you exactly. I'll tell you what it's called on the website. Answer Cancer Foundation.
It does appear that when we added the keto in on top of along with the Xtandi,
Mm-hmm.
it seems to have stabilized the PSA rise, and it even dropped a couple of months. So it's not rising nearly as fast. And like I say, one month, actually 2 months, it went down. So that may be an indicator to him that, you know, it's cancer is more responsive to keto / abiraterone than the Xtandi now.
Well, I just posted the link. It's the third up. It's the third up from the bottom right now. It says abiraterone versus enzalutamide. That's the webinar, and I just posted the link. I mean, you'd be an intriguing case to switch from Xtandi to abiraterone. You'd be a very intriguing case. I don't know enough about the technical stuff. I wish we had Bill Burhans on the call, or one of the other real technical guys. I just don't know enough about the technical side to know how abiraterone works versus how enzalutamide works. Does anybody on the call can contribute on that one? Okay.
I'm sorry, Rick, what was the question? The difference between enzalutamide and abiraterone?
Abiraterone, yeah. One of them works on the androgen receptors. I think that's the enzalutamide. The other one, the abiraterone, go ahead.
That prevents testosterone synthesis.
Okay.
Anywhere.
Anywhere.
Yeah.
So, meaning it stops the it stops the testosterone being produced because cholesterol can be broken down into testosterone, which is what the cancer does.
Right.
it makes its own testosterone from cholesterol, and that is what abiraterone prevents, and that also, I guess, is what ketoconazole does, how ketoconazole works, but to a lesser extent.
Yeah, that's my understanding too.
Okay, guys, well, we're 10 minutes over, but I didn't want to stop this because I think it was a good discussion. Jerry, will you come back either next Tuesday or, you know, in the next Monday session and tell us how you did with Snuffy?
Yeah, I'll do that.
Thank you. Thank you so much. And don't hesitate to be in touch with me if you need more help. And again, the old reminder, don't forget to sign up for Amazon, especially you guys who are in distant places that use Amazon a lot. And go to Amazon Smiles and nominate Answer Cancer because we benefit from that. And I'll talk to you all, and I hope that some of your caregivers will be on the call, on our first caregiver call tomorrow night. Okay?
Good talking to you guys. Thanks.
Okay.
Thank you.
Good night.
Good night, everybody.
Good night, Rick. Good night, everyone.
Good night.
Good night.
Right.
99.
Good night, good night.